Patients can complain of diplopia in clinic. Sometimes they have a slow eye muscle, like bradykinesia, just like the body can be. Impaired hue discrimination with greater blue-green problems. I may be screwing up the name of this, but it's the Farnsworth-Munsell, I believe, hue test. And what you're supposed to do is kind of arrange all these hues in different levels, going up in, to the right colors. And PD patients do this significantly less well than controls. So impaired hue discrimination. Why could that be occurring? Well, there's also dopamine in the retina, and PD patients may have some dopaminergic deficits in the retina as well. Trouble reading is a common complaint due to various causes. They're old usually, so cataracts, macular degeneration, all that kind of stuff can be there. And whenever they do have these structural problems in the eye, they're much more likely to develop visual hallucinations. That was shown by Dr. Wooten and colleagues at the University of Virginia where I trained. And they have impaired visuospatial discrimination, as I mentioned. This is the top part of the MoCA test. And you can see there that, hopefully you can see, that going, you start out begin here at 1, you go 1A, 2B, 3C, you just go each number letter alternating there. And this patient didn't do so well. So lots of trouble in this trail making test. The cube is beautiful. This is rare that a PD patient draws a cube this great with moderate to advanced disease when they have such a bad clock. This is a clock drawing test that should be round, and the number should be 10 minutes past 11 with all the numbers on the clock. And they did not do very well at all on that. They missed all the scoring for that. So this is a big feature that's well represented on the MoCA that's not very present on the MMSE. So also fatigue is a common aspect in Parkinson's patients. It's prevalent at all stages in Parkinson's disease, actually, even in early patients, and that was shown in a recent study. And up to the first year after diagnosis, maybe half of early PD patients have some complaints of fatigue. Other recent studies have shown that this fatigue component is associated with anxiety, depression, reduced motivation, kind of apathy symptoms, and Parkinson's severity and pain. Wasn't as much associated with gender and age. It didn't appear in this study by Shafito. Okay, next poll question. Which of the following non-motor problems may precede the motor symptoms of PD by 15 years or more in some cases? Dementia, dysphagia, depression, or REM sleep behavior disorder? I think I mentioned this, so you should get this right. Okay, got two responses at that time, but it's actually REM behavior disorder, REM sleep behavior disorder. The ability to move and do crazy things like scream and yell out, sock your bed partner, etc. in the middle of a dream when normally we're paralyzed. We normally have atonia in the middle of a dream. But REM sleep behavior disorder, if it's idiopathic, can precede Parkinson's disease by 15, 20 years in some cases. Patients that have REM sleep behavior disorder and no signs of Parkinsonism, if it's idiopathic and not related to sleep apnea or other issues, they can actually go on to develop multiple system atrophy, a cousin of Parkinson's as well. That's another synucleinopathy. Well, I mentioned prevalence of sleep disturbances in PD, and they're darn common. In a large study by Andy Lees in England in 1988, almost everybody had a sleep issue in Parkinson's disease. The drugs can make you sleepy. There's all kinds of sleep problems that can occur. Again, anywhere from 25% up to 100% of patients. I'd say in our practice, it's at least in the high 80s or 90s. What are the sleep disturbances you can get in Parkinson's disease? Trouble with recurrence of PD symptoms. You're trying to go to bed and your tremor is bothering you and you can't get back to sleep because your medicine's worn off. Or you're worn off in the middle of the night because you took your last dose at 9 o'clock or 8 o'clock and you're stiff and slow in the bed and can't turn over. So that's a very common, difficulty turning in bed is a very common problem. PD, drug-induced disturbances can also occur. So you have excessive daytime sleepiness, problems like that, where you're falling asleep even behind the wheel. Actually, as a warning label on doping agonist medications like pramipexole and ropinirole, you got to tell patients that you may fall asleep when you're taking this medication behind the wheel, and warn them about that as you start the drug. Sleep maintenance insomnia, where you can't stay asleep. I mentioned REM behavior disorder and its features. Restless leg syndrome occurs in 25% or more of PD patients, actually, and that's very common, and so it can be difficult to treat sometimes. The limb movements of sleep can occur associated with PLMS, can occur associated with Parkinson's or other conditions as well. And then there's obstructive sleep apnea, where that's common in many patients, especially as we get fatter in America. We're going to see a lot more of that. Sleep doctors, hypertension doctors, and endocrinologists are going to be racking up in the future with too many patients, I think. So that's common in all patients, including PD. Other conditions like having to urinate at night, old man prostate kicking in, etc. Pain due to off phenomenon or dystonia in the foot can wake you up in the morning at times. And depression, because you're worried or upset about a lot of things, can interfere with sleep, and those are all common features of Parkinson's. I mentioned RBD. It was first described in 4 elderly men, and you have this intermittent loss of REM sleep, atonia, where you should be paralyzed, and you have elaborate motor activity with dream mentation. So you got to have at least one of the following to make the diagnosis, and it's typically made by polysomnography, and you put a chin EMG monitor on the patient, and it shows increased chin EMG activity, no signs of epilepsy, of course, and it can be made pretty well with a sleep study. How about pain and sensory symptoms? About 50% of patients actually complain of pain with Parkinson's. They can have muscle cramps, stiffness, dystonia, these twisting postures of the foot or hand that can occur, especially when the patient's off. They can have pinched nerve roots, radiculopathies, joint pains from maybe dyskinesias or other things like that. Dyskinesias can cause severe erosion of joints in some patients. We've had patients have significant neck pain from lots of head dyskinesias and twisting of the necks violently at times. That can occur. Some patients have burning and tingling and numbness, especially when they're off. When their medications for Parkinson's have worn out, the levodopa especially, they can notice these burning and tingling and vague discomfort complaints come back in the more affected limb usually. They take their levodopa and then it goes away and improves. Many of these sensory symptoms can predate PD motor features, and the treatment typically is to try to increase the anti-Parkinsonian drugs and keep them on more. However, you may have to use narcotics or see a pain specialist sometimes. That can be quite difficult. How about constipation? A very common feature in the majority of PD patients. Also gastroparesis and other aspects of GI dysfunction in the upper tract can occur as well. Modify the diet, so more fiber, the usual, more water. May not drink enough water in PD in many patients I commonly see. Increase physical activity, so you're stiff and slow and rigid and not moving around very well, and getting active helps you have bowel movements, obviously. Anticholinergics that we use for tremor and other aspects of Parkinson's, like trihexyphenidyl and benztropine, can certainly worsen constipation. You want to stop those if you can. Stool softeners like docosahexaene sodium, lactulose, laxatives. One of the most effective ones I've used lately in practice is the polyethylene glycol, 3350 I think it is a generic name. It tends to help a lot of patients, and you can get that over the counter even, and it's quite effective, and they can use it daily. Orthostatic hypotension is also common in PD patients. It can be present both in early disease and later disease, but more often it's present in moderate and later stages of disease as something that's symptomatic. But